Thank you. Well, thank you very much for having us here today, and I do want to recognize Dawn Alley and her team with the work that they've done on the National Prevention Strategy and the Council. They've really inspired us and given us a lot of vision. It's been very impactful on DoD. I arrived at DoD a little over a year ago, and when I came, I was coming from the Office of the U.S. Surgeon General, where I had the opportunity to go into many places and rebuild health infrastructure with a lot of our response teams post Hurricane Katrina, where we had a lot of lessons learned. And that really informed us about health determinants and all the different components that make up a person's health. And DoD, when I got there, had done a great job at having a lot of primary preventive activities, many of them service-driven, many of them driven by the military health system, and many of them actually driven by the line. And we had collected a lot of information on it. But at the same time, what we saw is that the healthcare costs in DoD were increasing. They're greater than 10% of our DoD budget. And if you look at Department of Defense, you know, as a business, our business is the nation's defense, and we have a pot of money. And the more we spend on healthcare, the less we have for training, the less we have for equipment, and the less ability we have for doing our mission, which is protecting the nation. So this is actually a crisis for us. It's a crisis for the whole country. And so when we looked at what was driving up those healthcare costs, 65% of our healthcare costs are related to non-communicable diseases. And most of those are aggravated by obesity and tobacco use. And so it seemed to us that if we were going to do something, that was a place to start. Because not only did it drive up healthcare cost and directly affect our ability to do mission, it also impacted our resiliency and it impacted our readiness, because it increased numbers of injuries. If you're deploying away from your family, but your family isn't well, your daughter's just been diagnosed with diabetes type 2, you know, your ability to focus on that mission is also impacted. So to that end, we came up with this idea of Operation Live Well. And this is a multi-year strategy, a whole culture change that we are trying to incorporate across the Department of Defense. And one of the biggest ways we decided we would be effective in doing that is by creating an advisory board. There's not a public health department within the Department of Defense. Now, with our reorganization to the Defense Health Agency, there will be a public health component, and it will have representation that's much wider than it has been historically. This Population Health Advisory Board really wanted to partner with things like DLA, the Defense Logistics Agency, DODEA, which are our schools, DODECA, which are our commissaries, things like that, bring in the partnership. So Operation Live Well is really influenced very heavily by the U.S. National Prevention Strategy. It is specifically tailored to some of the unique environments of the military. Some of our struggles are the same that you face, and some are unique, and I'll go through those in a minute. And it's Dr. Jonathan Woodson, who is our Assistant Secretary of Health Affairs, who is actually leading this implementation, and I am his action officer on it. So while Operation Live Well brings together all of the resources and capabilities of the entire military community to promote health, we need it to be informed on what is the best way to do this. So our strategy is to really look at this in 3 phases. We have phase 1, which is an information, education, and outreach campaign, and that's what we've been doing for this past year. And I'm going to show you the 14 installations that we've gone to that are representative of the many environments that our folks live in. Phase 2 is we're going to go ahead and, based on a framework I'll show you in a minute, we're implementing initiatives, and we're putting metrics around those initiatives. One of the questions asked this morning by a gentleman was, we've been doing the right thing for so long, why do we have to keep proving that it's the right thing? Well, because the bottom line is there is not that much resources. We can no longer do primary prevention because it's the right thing to do. We have to demonstrate the costs avoided or the returns on investment so that we can continue to get that funding. Otherwise, it's the first thing to get cut. And I can tell you almost 100% of our funding was cut last year from many of our primary prevention initiatives. We were able to reclaim that funding by showing that we will demonstrate during this year the effect of our primary prevention initiatives. Phase 3 is going to be implementing a long-term strategy that we really will hope will lead to behavior change, and that will be implemented a year from today, or beginning to be implemented about a year from today. So right now, where we are at is we are in phase 1, transitioning into phase 2. We've gone out to many installations. We've gone ahead and done our assessment, and we are now looking at the following objectives. First of all, we need to optimize our health and performance. Second of all, we need to improve readiness, and we need to reduce healthcare costs, or Department of Defense will struggle to do its mission and protect this nation. We also need to provide DoD with a framework for best practices so that while we're demonstrating at these 14 installations what works, we can roll this out across DoD. In fact, we feel that we really need to partner with our communities because most of our folks don't live on base. Many folks live off base and in the surrounding communities, and as we heard this morning, that community really influences the health of our individuals. It's a partnership, and so we're going to be working with them as well. Our methods, first of all, we're looking at baseline metrics. We're looking at what is the current behavior of the population. While we don't feel like we're going to affect morbidity and mortality in a year, that's simply impossible. We can look at, are our initiatives moving people from a pre-contemplative stage to contemplation and activation? And then we can start looking at some of the biometric data. And from there, then we can start looking at the effect on readiness, attrition, and things like that. Our focus of our initiatives are really, like I said, on improving physical activity. What is the walkability, bikeability of the installations where folks live? Can we promote not just the physical activity, but better nutrition? When folks are walking into the dining facilities, they're really faced with a challenge. A large majority of Department of Defense is made up of 18 to 24-year-olds. They have, like many of your children, when they go off to college, a dining food card. They can go into that dining food. If that facility doesn't offer the right nutrition to fuel their bodies, they're stuck with consuming that or choosing not to. Many of them choose not to, and they go to the commissary and they buy food there. But they're living in a place where maybe they have a microwave to cook their food or perhaps a shared kitchen. So now they're spending a third time their money. So they had to contribute to the dining card. They had to then pay for food at the commissary if they wanted other options. And now they go out because they really didn't have time to cook. Maybe a dining facility isn't open at the right time for them because they're working on a tarmac at night fixing an airplane. So they go to the Snickers and the Coca-Cola and the vending machine or the fast food. So the people that are making the least amount of money are often spending more money because we just don't have a system that necessarily aligns with their lifestyle, offering food choices that are healthy and nutritious, that appear good, that they like, and that is accessible. So that's what we're doing in this Healthy Base initiative, is really looking at how do we, from a systems perspective, face the challenges and make the right choice, the easy choice, the healthy choice, the easy choice. I want to give credit there to Mr. Chuck Milam. He's the lead for the Healthy Base initiative. He's done a fantastic job with his team, and he has pulled together all of our community partners. This slide shows you the framework that we're looking at. This is informed by the CDC Healthy Communities as well as the National Prevention Strategy. We're looking at families, healthy food options, healthcare providers. What is the connection between the primary care provider and the primary prevention activities going on in the community? Our patient-centered medical home has done a tremendous job improving accessibility for our folks and including primary prevention. But how often do you go to the doctor? Right? If our health determinants are where we work, live, and play, there needs to be a connection between those primary care providers and what's going on out in the real world. And they can use some of their HEDIS metrics. They can use some of their other data that they collect. That's the difference between DOD and communities out here in the regular county, like Montgomery County. I can look at healthcare data that counties don't have accessible to them. And so we can really begin to see what is effective. And those patient-centered medical homes can use their data to work with the installations where people are living to drive some of the primary prevention programs, so you know what to resource and what not to resource. We need to make sure we have health in all policies, intersectoral and cross-sectoral collaborations. So we've talked about that a lot this morning. I'm not going to go through that, but the one thing I do want to point out that we've added to this wheel, this framework, is the strategic communication campaign. We have to make this meaningful to many different people. We know that there's the low motivation, low ability individual. We know we have the low motivation, high ability individual, the high motivation, low ability, and the high motivation, high ability. For those who are highly motivated and have a high ability to lead a healthy lifestyle, we need them to be leaders in the community. We need them at a grassroots level to help us motivate others. That could be the general's wife or the officer's wife who has the knowledge on what it is to eat well and eat healthy and feed their baby, versus the 16-year-old who comes in, or the 18-year-old wife who has now 2 children at age 18, and they're married to someone who's enlisted who earns a little bit of money and they still qualify for WIC. And so to save money, they're buying things like milk versus breastfeeding or formula feeding. And so we really want to get the high motivated, high ability folks to act as mentors to our younger folks who maybe have a high motivation but a low ability due to knowledge or other things like that. Next slide is, these are the bases that we went to. You can see they're around the world. We looked at bases that are rural, that are urban. We looked at bases that represent the Air Force, the Army, the Navy, the Marines, the Coast Guard. And we looked at bases that have schools, because if we have a large group of 18 to 24-year-olds that are coming in who might not have the education or the health literacy to make the healthy choices, we really feel like we can help shape culture at some of those schools where they're trained. What we found in general, like I said, for food and nutrition, we have a long way to go. Our biggest area is vending. We really need to make healthy choices available there. We need to get, just by positioning what food is available in a dining facility, we think we can make a change, putting the healthier food up front versus the stromboli, burgers, and pizza. If we put the salad and the fruit and the vegetables up front, we know that works. Special Operation Forces has the best dining facility ever down in Fort Bragg, North Carolina, and Air Force will truck their people in 20 minutes to use that dining facility several times a day. That's 40 minutes, 3 times a day, just to get to the right food. Okay, so they want it. The young folks do want it. It's not that they don't. Active living, we've got well-equipped rec programs and gyms and things like that. Our schools we're working with and doing a tremendous job across that, and the children and youth. Last but not least, the one thing that I did want to share with you, because I am out of time, health promotion councils. The biggest problem, I told you at the beginning that there's a lot of primary prevention activities that are occurring already in these communities. The problem is they haven't been communicating. There's not synchronization among them, and that has led to not using resources as wisely as we can. We'll need a strategic communication and a promotion council to make that work. And with tobacco, what we have found is that they're focused on performance more than they are on health. These folks live in the here and now, and our communication campaigns for decreasing tobacco use that focus on your jaw falling off in 20 years just doesn't resonate with them. So with that end, this is our way ahead. You can find us. We have a lot of metrics and outcomes. It's in your slides. Our information is up on all these sites. You can track Operation Live Well and the Healthy Base Initiative. Through this, we also, we're on Federal News Radio Morning Drive. There's a blog from September 9th there, and you can hear a lot more about this specifically on the measures and metrics if you want. And with that, I close.
Thank you so much. And now I'm very pleased to introduce Jennifer Ho, Senior Advisor in the Office of the Secretary at the U.S. Department of Housing and Urban Development.